Hello and welcome to Bite-Sized MRCP, a manageable way to digest the things that you need to know for your MRCP exam. We are two junior doctors based in the UK who have passed all three parts of the MRCP within the last 5 years and want to help you do the same. We're not associated with any MRCP examination organizations, and the materials covered are by no means an exhaustive list of what can come up in your exam, and indeed are not intended to be used as medical advice. Please refer to your College of Entry or your friendly supervisor for further questions regarding the exam and syllabus. If you like the sound of what you hear today and would like to join us for more bite-sized revision, give us a thumbs up and press the subscribe button. Now, without further ado, let's get into today's topic, which is on Clostridium Perfringens under the section of infectious diseases. So this is a picture of a slide showing Clostridium Perfringens. As mentioned previously, it's not a common question to come as part of the MRCP exams. However, they are completely within their rights to give you a slide of a bacteria as part of your Part 2 written examination and ask you to identify it based on an associated or an accompanied clinical history. So I think it's a good idea to have a rough understanding of different slides and bacteria. As for its epidemiology, it is found in soil. It's responsible for approximately 10% of foodborne outbreaks in the UK. Primarily, it's transmitted through ingestion of contaminated food, particularly meats and poultry that have been improperly sorted or cooked. Spores survive cooking temperatures and germinate during cooling and unrefrigerated storage. It can also, in extreme cases, cause gas gangrene. As for its pathophysiology, it's a gram-positive, rod-shaped anaerobic bacterium. It produces spores and it produces over 12 toxins. Food poisoning, it's often due to ingestion of contaminated meat, and gas gangrene is often due to infection in the wounds, leading to tissue death and necrosis. The clinical manifestation really depend on the type of the infection. As for food poisoning, you get abrupt abdominal cramps and diarrhea 6 to 24 hours after ingestion of the contaminated food, and it usually resolves within 24 hours. As for gas gangrene, it can cause severe pain, swelling, and bloody exudate in infected muscles, and it can progress to shock and renal failure if untreated. It certainly needs to be treated as a surgical emergency. The management of it for food poisoning is mostly supportive, with replacement of hydration and electrolyte as appropriate. Antibiotics are not typically used. The gas gangrene, however, is the complete opposite of that, and it's an immediate surgical emergency that needs surgical debridement of the necrotic tissue. The patient will need to receive high-dose penicillin G or metronidazole, and hyperbaric oxygen therapy has been proven to be beneficial in some studies. Let's do some questions. So, a 40-year-old man presents to the emergency department with severe pain, swelling, and dark blistering over the right forearm following a deep laceration he received while cleaning an old lawnmower. He has a fever of 38.7 and his blood pressure is 90/50. The affected area emits a foul smell and crepitus is noticed on palpation. His heart rate is 120. The most likely diagnosis is gas gangrene. Which of the following is the most appropriate initial management of this patient? A. High-dose intravenous penicillin G. B. Oral metronidazole. C. Intravenous fluid resuscitation and high-dose intravenous penicillin G. D. Immediate surgical debridement and intravenous vancomycin. E. Intravenous fluid, surgical debridement and high-dose intravenous penicillin G. So going back to the scenario, you will realize that this is a patient that is showing signs and symptoms consistent with septic shock, and that is having a high heart rate and associated low blood pressure. It's been easy on you by giving you the diagnosis that this is a gas gangrene, and it's pretty much just asking about the immediate management. You should all pick the option for intravenous fluid resuscitation, given that this is a septic patient. And if you recall from our slides earlier, you would realize that a surgical gas gangrene is a surgical emergency needing a surgical debridement. And intravenous penicillin G is the antibiotic of choice in the meantime until the necrotic tissue is excised. Thanks for listening to this episode of Bite Size MRCP. If you like what you heard today, give us a thumbs up and hit the like and subscribe button to make sure that you don't miss out on our next episode. Let us know in the comments which topics you would like to hear in the future. See you in the next episode.